Well, my name is Moises Waman. I am a faculty over here at the University of Kentucky, Division of Infectious Diseases. And thanks for inviting me. I will be talking about this lecture, this session is really divided in the first one. The first part is going to be today. We're going to talk a little bit about HIV and TB co-infection, some important aspects of diagnosis. And then next week, we will be talking about treatment, latent infection, LTBI infection, as well as tuberculosis disease treatment. So, and feel free to interrupt at any time if you have any questions. This is the list of the objectives. And as an introduction, I wanted to mention, we sometimes forget about this, but HIV and TB is really what we call a syndemic. You remember the concept of, an additive effect when we're talking about two different drugs, and then a synergistic effect, right? It's the same with HIV and tuberculosis, meaning that one affects the other and vice versa. So HIV is associated with a higher risk of tuberculosis infection. This is latent tuberculosis infection, tuberculosis disease, poor treatment outcomes, and higher rates of tuberculosis recurrence and relapse. Now, tuberculosis is also associated, this is looking this from the other side, is associated with enhanced HIV viral replication, more rapid progression towards AIDS, and higher rates of other opportunistic infections. So you can see how HIV affects tuberculosis, and tuberculosis also affects HIV. So that's why in the guidelines you will see that anytime somebody is diagnosed with tuberculosis, one of the things that you have to do is, if the patient has not been on HIV treatment, the patient should be started on HIV treatment. Now, we will talk next week about when to start treatment and all that, but definitely treating the two conditions is necessary. Now, you know about these 13% of worldwide incident cases of tuberculosis are HIV co-infected. So it's not that uncommon. Here in the US, we don't have many cases of HIV and tuberculosis co-infection, but if you take the whole HIV burden in the world and TB cases, it's 13% will have this co-infection. And there is some national data over here. We have less than 1,000 new cases of co-infection per year now. It's rare. In general, it's rare. There is still the most common opportunistic infection in some areas, such as New York City. And the important thing, why we always have these sessions on TB and HIV co-infection, even though the incidence itself is declining, it's because tuberculosis is transmissible. And this is just a world map to show you the tight correlation between the areas with higher rates of HIV, which will be in red, and the higher rates of HIV and tuberculosis co-infection, which are the dots. The larger the size of the black dot, the larger the number of HIV and tuberculosis co-infection cases. Now, this is a little bit, this can be a confusing figure, but the most important thing is this. Take a look at the y-axis, and you have over there HIV infection, and maybe I have, I have my, over here. So HIV infection here in the y-axis, and the CD4 count. And then in the x-axis, you have the M tuberculosis, mycobacterial tuberculosis, bacterial load. So the lower the CD4 count, in the course of HIV infection, the higher the chances that there will be replication of the mycobacteria. And this translates into these very impressive numbers over here in the left side. For example, if somebody, we're talking about somebody who is not infected with HIV and has latent tuberculosis, the rate of reactivation progressing to tuberculosis disease will be about 1%. 1% of infected persons with latent tuberculosis infection will reactivate every year. If we go to somebody who has HIV with a CD4 count above 200, that rate increases to 10%. 10% of the persons who are HIV, LTBI co-infected will progress to reactivation of the disease. And then if we talk about, let me see, where did it go? Okay, over here. If we talk about HIV persons who have a CD4 count less than 200, so those who are in the AIDS category, about 30% of them, a third of the ones who are co-infected with latent tuberculosis infection will reactivate within the next year. So it's a pretty tight correlation between TB reactivation and the CD4 count of the patient with HIV infection. Now, in terms of the tuberculosis course and presentation in HIV, we were talking about this progression from latent TB to TB disease is more frequent. There is risk of TB disease shortly after HIV infection, even before the CD4 count drops below 500. So it's not clear what exactly happens, but even if the patient has a pretty good CD4 count, there is still an increased risk for TB reactivation in that person. Even if the patient is on HIV medications and has a pretty good CD4 count, the risk of reactivating will be higher than somebody who does not have HIV. Persons on antiretroviral therapy who achieve virologic response, and this is what I was saying, will be at a higher risk of disease compared to the general population. So you're getting a good sense of how TB affects HIV and HIV affects tuberculosis. So I brought you a couple of cases that will illustrate a little bit of the complexity of how to diagnose TB. So this is a case from Tennessee from when I was a fellow. We have a 31-year-old male who was previously healthy, who comes in with 2 weeks of cough and fever. He's diagnosed with pneumonia, quote unquote, and he's given a Z-Pack. You know how many times we have seen this. And there is no improvement of symptoms, having sweats, and he's now reporting significant weight loss during the last month. And once he's seen again in the emergency department, he discloses his MSM condition. There is a rapid HIV test that is done, and he's positive. His vital signs, as you can see, are pretty unremarkable on presentation, except for a little bit of there is fever, and there was tachycardia as well. And on exam, he has significant lymphadenopathy, lymph nodes in the neck, as well as some bronchi in the bases, and his CD4 count is found to be 42, so we know that he's in the AIDS category, and HIV viral load is about 2 million. This is his chest x-ray, and you can see there is something going on over here, right? This is definitely abnormal. Now, if you look at this and you forget about the fact that this is an HIV person, the first thing that you could think about will be a community-acquired pneumonia, right? This is not somebody who is in the hospital. This is somebody who is apparently healthy. So community-acquired pneumonia treatment may have been indicated, and that's why he got a Z-Pack just recently. But then there is another finding that is important, that is what you can see over here. The mediastinum, it's a little bit enlarged, and you can better see that on a CT scan. He gets the CT. You can see some of the lymph nodes in the neck. Then you get into the lung parenchyma, and you start seeing some consolidation, which will be consistent with pneumonia, right, in the right upper lobe. And then you have the 3 centimeter or so mediastinal lymph nodes. So let me ask you guys, what will you do next? Will you prescribe oral levofloxacin for possible community-acquired pneumonia? Will you think about tuberculosis and isolate this person, work up for pneumonia, including AFP stains and cultures? There is no need for isolation, but you will do your routine workup for community acquired pneumonia, or you will call oncology due to possible aggressive lymphoma. So what do you think?
Oh, let me just make sure everyone's unmuted. Okay.
Isolate the patient. Okay, good. Is there what caught your attention? What will be the potential risk factors? Why wouldn't you think about just a community acquired pneumonia case?
With the CD4 less than 47, I'm starting to think he might have just may want to isolate that.
Okay.
He also has fever, cough. He's symptomatic.
And it has been going on for at least 2 weeks, right? And he's having some constitutional symptoms. Yeah. And the other thing is the lymphadenopathy, the mediastinal lymphadenopathy. I mean, this could be, the differential is broad, could be histoplasma, etc. But yeah, CD4 count is low. You may not have that information when he presents. Remember, in the ED, when you're making that decision, you only know that this patient is coming with with persistent symptoms and a positive rapid test. So you know that he has HIV. You may find out in the regular CBC with differential that he has a little bit of lymphopenia, and you may think about profound immunosuppression, maybe in the AIDS category, but you don't know about the CD4 count at that time, but you have to make a decision. So yes, I think the best thing to do for a patient like this, especially if this is somebody who was given some treatment, didn't really get better, and is still having persistent symptoms. And the CT is definitely abnormal, and you have lymphadenopathy. So TB has to come to your mind, and you have to think about that. So the next thing is, well, let me just summarize this. This patient got a bunch of tests. He ended up getting a lymph node biopsy, and you can see the pathology over here. Now, what is one of the most common histopathologic findings of tuberculosis whenever you do a biopsy? It's granuloma formation, right? We always talk about, okay, there is a caseating granuloma, necrotizing granuloma, then we think about tuberculosis, right? There is nothing like that over here. There is no granuloma, and we will mention that later. Because of such a low CD4 count that this patient had, he may not be able to mount an inflammatory response potent enough to form granulomas. So if there is no granuloma in somebody who is HIV/AIDS, that does not necessarily rule out tuberculosis. Okay, and then you can see you can see some of the rods over the bacilli. They are. Let me see if I can show them over here. Yeah. This is an AFP stain, and it's a palsy bacillary disease. So just a few of them, just 3 in this field. It was a very difficult diagnosis, but he ended up growing as well mycobacterium tuberculosis. So this is a second case. We have now a 66-year-old Hispanic female. She's in Kentucky. And she has been here since 1999 when she was diagnosed with HIV. She hasn't gone back to, I believe she's from Guatemala. Well, yeah, she's from Guatemala, I believe. And she has been on antiretroviral therapy, different regimens, very non-compliant. And her most recent regimen was valtegravir and Truvada. And her most recent CD4 count, as you can see, was 457. And her viral load was detectable at 15,000, even though she was supposed to be taking her medications. But we know that she hasn't, right? She hasn't been taking them as she should. And comes in with cough for a couple of months, for 2 months, an occasional whitish sputum. She's having no fevers, no chills, no weight loss, no hemoptysis. And I have to tell you that she's a COPD patient. And she said, oh yeah, this started 2 months ago, but cough is not something unusual for me. And she has some other comorbidities, hypertension, a CVA, and a stroke in the past. And apparently she was diagnosed with latent tuberculosis infection. It will be 14 years ago. And it's not clear to us when she presented, but she was apparently treated with INH through the health department. So interestingly, this patient was seen 6 weeks prior. So that's when she was having cough for about 2 or 3 weeks. And a chest x-ray was done. Her PCP ordered that. And there was a left upper lobe nodule. And this led to a CT scan which showed bilateral upper lobe nodularity. And then she's referred to pulmonary, but her appointment, for some reason, was scheduled very late, and she still has to wait another month to see the pulmonologist. Okay, so take in consideration all this information, and let me ask you. This is her CT scan. Okay, so in the right upper lobe, you can see this nodule over here. Okay, these may be. It's not very concerning really, but then in the left upper lobe you see something that it has a kind of a nodular appearance, but it's very atypical. It looks a little bit different. It looks like an early infection really, and in this case, what would you do? Remember, she has been coughing for 2 months. She's a COPD, possible LTBI in the past, HIV, CD4 count in the 470s. And she has a pulmonary appointment in a month from now. So will you just wait for the pulmonary evaluation? I think the main concern was, the nodule. And will you order a quantiferon TB test? Will you place a PPD? Will you work up for active TB with 3 sputa? Will you contact the health department? And you don't necessarily have to choose just one, but what do you think?
Well, in my area, people automatically contact the health department, and that's me. But we would probably do the quantiferon, which we do T-spot.
Okay. Now, will you still do the quantiferon if she was diagnosed with LTBI back 14 years ago, maybe based on a positive PPD?
Well, I mean, we could try to get records to see. I mean, that's patient information. I guess she's just telling us off the top of her head that she thinks that was the case.
Okay. Yeah.
I mean, we wouldn't want to do a PPD because that's 2 visits, and if she has already had it, it's going to be positive anyway.
Mm-hmm. Yes. Now, it could still be. So now this is a problem, that if she was truly positive 14 years ago and she's positive now, that doesn't mean anything, right? You're going to be positive lifelong. And if in terms of the PPD, if the quantiferon TB is positive and she was PPD positive 14 years ago, again, it doesn't add much value. It may confirm that she was truly positive 14 years ago. I think the key information is going to be if she truly got treatment, right? Because that may decrease her risk a little bit moving forward, right? But yeah. I mean, I think in this case we got a quantiferon TB just because it wasn't clear what had happened 14 years ago. As you said, it's very difficult to get those records. But in terms of clinical decision making, may not help much. Just because you're kind of assuming that she was positive already. So it's expected that it's going to be, if you do a PPD or if you do a quantiferon, it's going to be positive.
So if we skip that step, then we're going to do the sputa next.
Good. Yeah, definitely. And contact the health department. And we also work with our local health department. Sometimes this patient was, and what about, before getting to this, what about just waiting a month and letting pulmonary deal with this? Is there anything that I mean, she's not having fevers. Let's go back. She's not having fevers. She's not losing weight. She's a COPD. She may be coughing because of that. Why not just wait a month?
My thought is she's already been coughing for 2 months. Wait another month. That's 3 months before she gets evaluated. And I guess just because I do deal with TB, the the thought of her walking around coughing out TB for 3 months is not something I want to deal with.
Yeah. So and you're right. I think the clinical presentation is not that not that typical. But and even the CT scan, I have to tell you, is not that typical. You wouldn't think the first thing that will come to your mind wouldn't be tuberculosis, really. And that nodule in the right side in somebody who is COPD could be a number of things, including cancer as well. But this other one in the left side was a little bit concerning to me. Any other thoughts? Any other thoughts over there?
I like Robin's answers.
What was that?
I like Robin's answers.
Yeah.
Okay. So so we had her in the office and she was coughing. So we went ahead and got the first sputum over there, and then we got we did another 3 through the health department, including an MTB PCR. And stains were all negative, and the MTB PCR was negative. So at least we were feeling a little bit better with that finding. But then the patient started having some subjective fevers. We ended up admitting her. She ended up getting a bronch. The thing is that she ended up growing MTB from 2 out of the 3 AFB cultures that were initially sent, even though her MTB PCR was negative and her stains were all negative, including an MTB PCR from her bronchoscopy and the AFB stain from the bronchoscopy, from the BAL. So this is just to show you how difficult sometimes is to make this diagnosis. But she was definitely in the early stage of developing MTB, or mycobacterium tuberculosis reactivation. And then we went back and took a look. We were able to get the records of when she was apparently treated for latent TB infection 14 years prior. And she was honest with us. She picked up all the bottles, the 8 refills, to get her to 9 months, but she never took them. She did not take one single pill. So she wasn't really treated. And that's the other thing that you have to remember. Not because the patient fills the prescription, that means that the patient took the medication, right? Okay. Do you have any questions about this second case? This second case is a little bit more atypical. It's a little bit difficult to get to the diagnosis, but as you said, you just have to think about TB. She's originally from an endemic area. She has HIV. You know that HIV increases the risk of reactivation, and she is already known to have LTBI. Her quantiferin was obviously positive, and you don't really know if she truly got latent tuberculosis treatment or not. There's no questions, right? Okay. So let's talk about this real quick. TB course and presentation in HIV. Remember, and this patient, the second patient, it's a very good example of this. Fewer symptoms, subclinical disease. They may be walking around, not even having a cough, and you do a chest X-ray and there is something going on. Extrapulmonary disease is much more frequent. In some series, it gets up to 80% of the cases of HIV and TB co-infection. The most common extrapulmonary site will be the lymph node, about 43%. And the mediastinum is the most common one, similar to case number 1. The case number 1 had TB in the lungs and TB in the lymph node. Then pleural TB is also common. CNS, we deal with that every once in a while. We had a case recently with CNS TB co-infection, and the risk of iris, we'll talk about that, it's relatively high. And then there is GI, genitourinary, musculoskeletal, etc. Now, the chest X-ray, and this is very important, is also very atypical. So your clinical suspicion has to be high, because up to 1/5 of the patients may have a normal chest X-ray. And this is data coming from endemic areas, obviously, may have a very normal chest X-ray. And let me show you, I should have included the chest x-ray of case number 2. But case number 2 went for a CT scan because of this nodule over here. And that nodule was not tuberculosis. I can tell you almost 100% sure that this was not tuberculosis, but this led to the CT scan. And what was really abnormal was this over here that wasn't seen on the chest x-ray. So a little bit of this haziness over here. So AFP smear negative disease is more frequent. Similar as exemplifying case 2, you can have 3-4 smears negative, and then 3-4 weeks later, your culture is positive. The good thing from a public health perspective is that the patient may be not at a high risk for transmission, so that's good. But well, there is always a risk. And granuloma may be absent on histopathology, as in case number 1. Now, how do you make the diagnosis of tuberculosis disease in HIV? So the history is the most important thing. You have to have a clinical suspicion. You have to ask about risk factors. Where is the patient coming from? Is the patient being in jail? What about previous TB screening tests? Who has the patient being around? IV drug users, homeless population, etc. And even though some of our HIV patients may not have gone back to their home country for a number of years, they may still not only be at risk of reactivation of a remote infection, but they may be getting in contact with active TB cases. Because remember, I mean, I'm originally from Peru, for example, and I have family members who will come to visit me who knows if somebody is developing, active TB. So even though I may not go with every year, I may still get exposed just because of my environment. So remember that. Sputum AFP stain and cultures are the main thing. And when we're talking about tuberculosis disease, the role of the TST, of the PPD, and the IGRA tests are not is not that great. I mean, it doesn't really help to rule out tuberculosis disease. It is great if it's positive, but if it's negative, you shouldn't stop. If you have clinical suspicion about tuberculosis, you have to do your sputum stains and your sputum culture. And ideally also, if your suspicion is high, you can ask the health department to do an MTB PCR for you. So the other thing is that, well, we may talk about this a little bit more the next time, but we also have the capability in most of the states to do MTB and rifampin, the gene expert, that will not only give you a positive result for presence of MTB, but will also check for a particular mutation that will be associated with resistance to rifampin. And the interesting thing about this is that about 80% of the cases, 80% of the isolates that are rifampin resistant will also be INH resistant. So it's a good proxy for MDR tuberculosis, MDR, multi-drug resistant tuberculosis, which is defined as having rifampin as well as INH resistance. So whenever we find rifampin resistance, we always think about rifampin and INH, and we have to think about a possible MDR case, and we have to come up with a little bit of unusual regimens depending on the history of the patient. Now, in terms of the nucleic acid amplification tests, the PCR tests, they have high predictive value of tuberculosis in AFP smear positive. So this is very interesting because sometimes, and this becomes an infection control issue, sometimes I may have in the hospital somebody who is 3+ AFP, and the health department will do an MTB PCR for us, and it's negative. And the negative predictive value of that negative result is very high. We're talking about 98, 99%, to the point that I can pretty much remove the patient from isolation. But remember, this is in somebody who has a positive smear. Positive smear, that they have a high predictive value of tuberculosis. MTB PCR positive, very good sensitivity, specificity. MTB PCR negative as well, a good specificity. However, if somebody has a smear negative, the sensitivity of the PCR is much lower. We're talking about 50%. In some cases, you may get to 70 to 80%, but it's not great. So if the smear is negative and your PCR is negative, there is still a chance that the patient could have active tuberculosis. And that's why, for example, in this second case, you get the diagnosis after 4 weeks when your culture starts growing, okay? So this is the most important thing. And I want you to remember that whenever you're suspecting tuberculosis, you can do a TST, you can do an IGRA, but you really need to do sputa studies. You really need to get a sputum. That's what really counts. If the TST is negative, or if the IGRA, whatever it is, TB spot test or quantiferon is negative, but you have a clinical suspicion, go for it. Go for the sputum, and you may end up getting some surprises. Yeah. Do you have any questions about this? This is the most important part of the talk today. Is it pretty clear?
Sir.
Okay. Good. So what about latent TB? This is latent TB is probably what we're going to be dealing the most over here in the US. So when to test? When should you test your HIV patients? When your patient is diagnosed with HIV, that's when you have to test for LTBI, regardless of risk factors. It doesn't matter if there are no risk factors. We do it. And then if the patient presents at intake with a CD4 count less than 200, you should repeat your test, either PPD or an IGRA, once the CD4 count is above 200, okay, above 200. And I think Brittany has some good information in her presentation. This will be next week about the pros and the cons of PPD versus IGRA, so I won't get into that. I'll let her do that next week. But whatever screening test that you're using, if your patient was in the AIDS category with CD4 count less than 200, you have to repeat it once the CD4 count is above 200, just because the sensitivity is so low for IGRAs or for PPDs when the CD4 count is less than 200 that sometimes I may not even check it. You will be lucky if it's positive, but yeah, the sensitivity is low. So how to test? You know about the TST, and if somebody is HIV co-infected, the threshold is 5 millimeters. Remember that for this, the patient will have to come back 48, 72 hours later, and it will have to be read by somebody who has experience. That's the other thing, that whenever I get patients in my clinic who come with either a negative or a positive PPD, and I'm thinking about tuberculosis, but this was not read at the health department, I repeat it, because it really depends on who is reading the TST, and you really have to trust whoever is doing it for you. So I will send the patient to the health department. I wouldn't even do it in my clinic. I would just send the patient to the health department and get a good TST. IGRA, we have the quantiferon and the T-spot TB test. We'll talk a little bit about both of them. IGRA has higher specificity, remember, especially in prior BCG vaccinated patients. So for example, in this patient who was from an endemic area, who was coming from, I believe I said Guatemala, then where BCG is common, BCG vaccination is common, then your quantiferon or your TB spot test may have a higher specificity. Now, the routine use, this question comes up frequently. The routine use of both TST and IGRA as being tried. Some providers may do that, and this is not that uncommon, especially in the rheumatology world. The patients were going to go into biologics. Sometimes, depending on the risk factors, the rheumatologists may do a TST as well as an IGRA, and there are actually some guidelines out there to support that. But this is, at least based on our current guidelines for HIV patients, this is not recommended in the US. So you either do the TST or the IGRA. You don't need to do both. And then what to do if the TST or the IGRA is positive. So then you need to rule out active disease, and that is your chest X-ray. But remember that you can miss some tuberculosis, active tuberculosis cases with your chest X-ray. So it's your chest X-ray, but also your symptoms. Symptoms are very important. And the traditional definition is cough, 2 weeks or more, but I usually go by cough. If the patient is coughing, regardless of the duration, I may get worried about you. And I'll definitely get a chest X-ray on everybody. And you have, this is just a picture of the TST. This is the quantiferon test. We do this over here in Kentucky quite frequently. There are 3 tubes. There is a positive control over here, a negative control, and a tube that has M tuberculosis antigens, M tuberculosis peptides. So what we really do is we put the blood of the blood of the patient is here, right? And we'll get in contact, will be challenged by the M tuberculosis peptides. So if there is a positive reaction, the lymphocytes of the patient are going to produce interferon, and the interferon is going to be what is going to be measured by the ELISA machine. So if there is interferon production when the lymphocytes of the patient are exposed to MTB peptides, then you have a positive quantiferon. And that's why when the CD4 count is low, the test may be falsely negative. Because remember, you're looking for interferon gamma production of the lymphocytes of the patient. And if you're starting with a low number of lymphocytes, then it may just be negative because the patient doesn't have enough lymphocytes. And that's why you have to repeat your test once the CD4 count is above 200. The T-spot test is a little bit different, but it's the same concept. It also captures it also measures interferon gamma production. But the nice thing about this, and that's why some experts will recommend doing the T-spot test, especially in patients who are immunocompromised, and in the case of HIV patients, there will be HIV and CD4 count less than 200, is because in this first step, let me show you here, the white blood cells of the patient, including the lymphocytes, will be separated from blood, and they are counted. So you have to get to a minimum number of lymphocytes that will get to the assay for this to proceed to the next stages. So that's why there's a little bit of a standardized number of lymphocytes that is required. And that's why there are studies that show a little bit of better sensitivity of the T-spot test when you're dealing with somebody who has low lymphocyte counts, anybody with a CD4 count below 200. So just remember that there may be an advantage of T-spot test over quantiferon when you're dealing with AIDS patients. And I'm kind of running out of time, so I won't go through these, but it's basically the dots are showing interferon gamma production. So the positive results to your right, and then the negative results to your left. And this is something that I would recommend you to look at. This is a website where you can put information of your patient, and it will give you, the interesting thing is what you get in the right side of the screen. So let me go through an example. So this is an online TST or IGRA interpreter. So you put the TST size if you did it, or you put the result of your IGRA test over here, either your T-spot test or your interferon. The age of the patient. If the patient is from out of the country, when did the patient come to the U.S. or to the lower endemicity country? The country of birth. If the patient was vaccinated, BCG vaccinated, and the nice thing about this is that most of our patients won't remember. I mean, who is going to remember if got BCG vaccinated? But the nice thing is that over here you have access to the BCG World Atlas, and it will tell you, like for example, in Mexico, pretty much 90% of the kids will be BCG vaccinated. So you kind of have to assume that everybody has been BCG vaccinated. And then there are some other risk factors that this will ask you for, like recent contact with active TB. And then there is somewhere where you can choose, where you can select that the patient is HIV infected. And then, as I was telling you, the nice thing about this is that it gives you some numbers. So it tells you that for example, for this particular patient, the likelihood that this is a true positive test, because there are also those issues of true positive, false positive, true negative, false negative, TST, or IGRA test, right? So it tells you, and you can give these numbers to the patient, and the patient can make decisions based on this. Because we won't get to this today, but treatment of LTBI and TB disease you're going to monitor side effects, but side effects can happen. And I have to tell you, for example, right now we have a patient who's in the hospital who unfortunately developed acute hepatitis to the point that she's pretty sick and intubated from getting LTBI treatment. So these things unfortunately can happen. So you need to talk to your patient about what are the pros and the cons of being treated. In general, anybody who has LTBI infection, latent TB infection, and HIV should be treated, just because the risk of reactivation is that high that definitely the benefit is much, much higher than the risk of complications. So, for example, going back to this patient, the likelihood that this is a true positive test is 98%. And then it also gives you an estimate of the annual risk of developing active tuberculosis disease. So you can tell this, you can give these numbers to your patient, and that way your patient can make a decision, a good decision. And then the cumulative risk of, for example, just putting HIV in the interpreter will give you that if we're talking about a young patient, somebody with 45 years old, if that person is not treated and has HIV, the chances that at some point he's going to reactivate tuberculosis are pretty high, close to 100%. And the final thing that I like is that it gives you a little bit. It doesn't really adjust for co-medications that the patient may be taking or hepatitis B or C, but at least it gives you a probability of significant drug-induced hepatitis, for example, and the probability of hospitalization due to drug-induced hepatitis. So there you go, and you can tell the patient what the risks are of taking, for example, INH. Yeah.